Welcome to this series of lectures in oral medicine, this one entitled White Lesions of the Oral Cavity.
Lesions can be subclassified under congenital, inflammatory, non-infective, neoplastic, or possibly even pre-neoplastic, and others. White lesions also we can look at in terms of benign chronic white mucosal lesions, oral pre-malignancy or potentially malignant disorders, and oral cancer. First of all, if we look at what causes the colour white that we see, it's as a result of increased thickening of the keratin layer, which is the top layer of the epithelium. And it is also a function of how light hits the mucosal surface. So if you have corrugations, obviously the colour is going to change. Leukoplakia is basically a term to mean white patch, and it's a clinical term and should be used to recognize white plaques of questionable risk, having excluded other known diseases or disorders that carry no risk of increased cancer. Diagnosis is clinical and does not imply pre-malignancy. So some benign chronic white lesions include common ones such as leukodema, frictional keratosis, cheek biting, Fordyce granules, stomatitis nicotina, and thrush or candidal infection. Some uncommon ones may be chemical burns, hairy leukoplakia, as can occur with HIV infected people, white sponge nevus, chronic candidiasis, psoriasis, oral keratosis of renal failure, vericiform xanthoma, and skin grafts. So if we look at some congenital lesions, Fordyce spots are quite often, if one has not seen these lesions clinically, can be quite alarming if you see it for the first time, but they're basically sebaceous glands and often evident in children and adults. No treatment is required. If you have a look in this picture, that's classical Fordyce granules. Once you've seen it, there's no need to do a biopsy. White sponge nevus, on the other hand, is a hereditary disorder that may involve any part of the oral mucosa, and here the edges are not well defined and merge with the normal mucosa. Superficial layers of epithelium are soft and of uneven thickness, so you get a shaggy or folded surface appearance, and they're usually bilateral, as with most developmental problems. Dyskeratosis congenita is a rare autosomal dominant lesion and affects, basically in this lesion there's a problem with the keratin, and there's a question mark as to whether this is a pre-malignant lesion. So here you have that folded appearance, as mentioned before, of white sponge nevus. Leukodema is particularly evident in people with racial pigmentation of the oral mucosa, usually translucent milky whiteness of the mucosa with slightly folded appearance, possibly due to local irritation, and it's a hereditary condition which is basically suggested to be a variation on normal. So here basically you see this milky white appearance of that buccal mucosa, and again here in a dark skinned person. If we now turn our attention to inflammatory lesions, these could be keratosis or keratosis, which is increased thickness of the keratin layer, may occur due to mechanical friction, thermal, as in smokers or burns, especially pizza burn or pie burn of the palate, chemical burns also, such as medication held against the buccal mucosa, such as aspirin, to relieve toothache. So frictional keratosis, as seen here, evident with sharp teeth, and what happens there, if it's an acute situation, you basically get a blister or ulceration through trauma, but in chronic trauma you get epithelial thickening, increase in the thickness of the keratin layer, like a callus, and you may see some sharp teeth, cheek biting, or ill-fitting dentures. Treatment is all by resolution of the course, such as reducing a sharp tooth or adjusting a denture. chemical keratosis, as indicated before, aspirin burn, where the aspirin is held against the buccal mucosa. Tobacco can cause mucosal changes, beetle nut, and again, hyperkeratosis is similar to chronic friction. Smoker's palate or smoker's keratosis or nicotinic stomatitis develops in association with smoking, especially pipe smoking. Early lesions, you may find the palate is grey or greyish white with scattered red spots which correspond to the opening of the minor salivary gland inflamed ducts. Advanced lesions are tessellated and rough white epithelium, red umbilicated duct orifices may be seen. Reverse smoking, reversible if smoking is ceased, and it's not a pre-malignant condition but an early warning sign that changes may be occurring. Again, a high-power view of smoker's palate. Candidosis may present in different clinical forms. On the top left here, it's a pseudomembranous candidosis where that white curdy surface will rub off, leaving a red underlying surface. Here there's erythema, which corresponds to the anatomical surface beneath a partial denture. You can also get angular cheilitis, which is a combination of a candidal and staph infection. Medium rhomboid glossitis, its name taken from the fact that it's in the middle of the dorsum of the tongue and it is rhomboid in shape. So if we talk about fungal infections in general, Candida albicans is the most common, but there are others, members of the family, that can occur, and it's a notorious opportunistic pathogen, so they wait until conditions are right and they attack. Carriage rate is about 20% of the normal oral flora, and it's a harmless commensal in the mouth of nearly 50% of the population. They become opportunistic pathogens following a disturbance to the oral flora and in decreased immunity. Increases to 40% in the presence of medical conditions, pregnancy, tobacco smokers and denture wearers, such as in those sort of situations where children, there's a peak carriage, 40%, 45% at 18 months. Primary site is the dorsum of the tongue. But the mechanism by which they induce disease is not really known, but probably through secreted enzymes, toxins and antigenic response. So local factors that predispose to infection may be mucosal trauma, denture wearing or tobacco smoking, which basically changes the local environment. Extremes of age, again this is at the young age or very old, you have a lowered immunity. Medications such as broad spectrum antibiotics, again changing the oral environment. Serostomia, such as so through drug medication or radiotherapy, or syndromes such as Sjogren's syndrome can predispose someone's oral cavity to candidosis. Systemic disease, HIV, iron deficiency, diabetes, again all of these tend to reduce the local immunity. The three most common clinical presentations are acute pseudomembranous, also called thrush, where you get a thick white coating on the affected mucosa which wipes off, leaving a red surface. It resembles milk curds and often caused by medications such as corticosteroids or antibiotics and immunosuppressants. Diagnosis by taking a smear of that with a sterile spatula and smearing it on a glass slide, transporting it and staining with PAS to see the fungal or the candidal hyphae. Management involves treating of the predisposing factors as well as antifungal medication. Chronic atrophic candidosis, also called denture stomatitis or medium rhomboid glossitis. There's erythema usually associated with this rather than a white appearance, often related to denture hygiene. Angular cheilitis often has a co-infection of Staph aureus. There's a soreness and erythema fissuring at the corners of the mouth. May have some nutritional deficiencies, so may need to test for that, folic acid or vitamin B12, or it may be associated with diabetes. Chronic mucocutaneous candidosis, where there's a number of rare congenital syndromes with persistent candidosis affecting the mouth, skin and nails and other areas. Candidal leukoplakia, or chronic hyperplastic candidosis, is suggested to have higher risk of potentially malignant change, and smoking tends to predispose people to this condition or this infection, and typically on the dorsum of the tongue or post commissurial buccal mucosa. So in this picture we have acute candidosis or thrush, which wipes off, and if you do a stain with PAS under the microscope, you can see these strands of hyphae, and that's diagnostic of an infection. Hairy leukoplakia basically occurs on the lateral borders of the tongue, and it basically corresponds to a thickening of the filiform papillae, and can often be seen in HIV infected, but can also be seen in non-infected people. Papilloma, squamous papilloma, which may have the appearance of like a cauliflower or fronds, and often it may be associated with HPV infection, and it's a benign lesion. You just simply excise it, and if you look at it under the microscope, you'll see this hyperplastic epithelium with the core of connective tissue, and there may be some areas of, you can see the blood vessels in red. Syphilitic leukoplakia is rare, associated with tertiary syphilis, usually on the dorsum of the tongue, and it has a high risk of malignant change. The primary lesion, secondary lesion and tertiary lesions can occur depending on how long the person has had the infection for. Congenital syphilis also is a possibility, in which case a patient may present with Hutchinson's triad, which is Hutchinson's teeth, ocular interstitial keratitis, and eighth nerve deafness. Now if we turn our attention to white lesions of non-infective origin, things such as commonly that present in the clinical situation are lichen planus. So these are the various clinical presentations of lichen planus. And we talk about old ladies in white lace, so they have that lace pattern, usually in old ladies greater than 40 years old, long-lasting. Buccal mucosa more affected than the tongue, more affected than the gingiva, and is usually bilateral. 15% may have cutaneous lesions. And a lichenoid lesion is something that appears similar to lichen planus, especially histopathologically, but it's probably due to something like a drug reaction and or a reaction to dental materials, such as, so these are some examples of medications that can cause this typical lichen planus appearance. So if we look at the histopathology, you have an atrophic epithelium with this band of inflammatory cells. All these dots are chronic inflammatory cells, and you have the basal layer, what we call liquefactive degeneration. So they die off, and there's not such a good demarcation between the epithelium and the underlying connective tissue. As suggested before, you can have many different clinical presentations. Need to be careful that systemic lupus erythematosus can also present very similarly histopathologically as well as clinically, but these tend to be generally or usually unilateral, but bilateral can occur, and often if in those cases where they're borderline, to be able to be diagnosed histopathologically, you need to do immunofluorescence to distinguish between. White lesions of neoplastic and possibly pre-neoplastic origin. So when we go from white to red, the malignant potential in general goes from least to greatest. But there is variable risk. Dysplasia, presence of dysplasia is the best predictor. So erythroplasia, which is a term for red patch, has a very high malignant potential, whereas something like lichen planus has a low potential. So the risk factors are a history of tobacco products, use of tobacco products, alcohol. Tobacco by itself and alcohol by itself has an increased risk, but when you combine the two together, you have a synergistic effect. There's a family history, especially with certain cancers. Age, obviously, to do with immunity. There may be reddening and speckling or nodules and ulceration. Sight is important. We know that lateral margin of the tongue, floor of the mouth, ventral surface of the tongue, pillar of the fauces region are high risk sites. Large lesions also may be a high risk factor. Long-standing lesions, a lesion that changes in appearance, and histopathologically the degree of dysplasia, whether it be mild or severe. So here we have epithelium under histopathology showing changes. There's hyperchromatism, varying shapes of cells here, and here again it's a haphazard arrangement, and you can see that this doesn't look like normal epithelium, and here the epithelium looks like it's going to drop off and invade the underlying connective tissue. So these are examples of leukoplakia, again clinical term for white patch that otherwise can't be designated into another disease. Or oral mucosal squamous cell carcinoma may have this appearance as well. So here we have chronic hyperplastic candidosis. Here we've got oral mucosal squamous cell carcinoma, which under the microscope you'll see this subepithelial keratinization, keratin whorls or formation of keratin deep in the connective tissue, which you wouldn't normally see. So erythroplakia, you have a well-defined, depressed, velvety lesion, which is uncommon. Often these are malignant at first biopsy, especially from a high-risk site, whereas leukoplakia, again, can be malignant, especially in high-risk sites such as ventral surface, lateral surface, or floor of the mouth. Chronic hyperplastic candidosis or candidal leukoplakia, again, this doesn't wipe off. It's a white patch that's, if you took a biopsy, you can stain for candida and you'll get positive hyphae. These are usually resistant to treatment, but often what you would do is treat them with antifungal and maybe re-biopsy. So principal management of dysplastic lesions, so these are at-risk lesions. You stop any associated habits such as alcohol and smoking. Treat the candida and or iron deficiency, so improve the immunity, do a biopsy, assess the risk of pre-malignant change on the clinical or histological findings, so whether they are mild, moderate or severe dysplasia. Consider ablation of individual lesions, but maintain observation, very important. So oral cancer, SCC, possible carcinogens, we talked about these, especially for lip cancer. Sunlight is an important factor, but tobacco, alcohol, erica nut, infections, what role do candida and viruses play? Mucosal disease such as lichen planus, genetic conditions such as dyskeratosis congenita. And we know, we've already talked about the high-risk sites. The 70% of the cancers in the shaded areas occur in the shaded areas, and the shaded area is only 20% of the mouth. So here are some examples of lesions that on biopsy would turn out to be oral squamous cell carcinoma. So what you see is pathologically is this disruption to the normal structure, and you get this inflammatory reaction, and you get invasion of these epithelial cells deeper. It's a bit like an avalanche. So you get this dysplasia that when it turns into SCC, it basically invades the underlying connective tissue. So with oral cancer, early white or red patches or shallow ulcers are usually painless. Later, the ulcers may become raised, rolled, or indurated clinically. 95% are well or moderately well differentiated SCCs. Um, they spread by direct invasion and through lymphatics. Submandibular or jugular digastric nodes are the most frequently involved. Prognosis deteriorates sharply with local spread, nodal involvement, and or size of the lesion. So if we talk about ulceration, traumatic ulceration, you know that biting through sharp cuffs or fitting dentures, you're going to get an irregular border of the lesion, um, typically of a traumatic ulcer. Recurrent aphthostomatitis, these are common and about 11 to 20% of the general population, and they're usually immune mediated. Females are affected more, and there may be three types. You've got minor, major, and herpetiform, which will be covered in a further lecture on ulceration. But remember that recurrent aphthostomatitis may be associated with other conditions or syndromes or other medical backgrounds, and you need to perhaps sometimes be aware of that and do some tests to eliminate them as a cause. So we talked about minor, which is less than 10 millimeters in diameter. They heal without scarring within about 2 weeks. Major, which is greater than 10 millimeters in diameter, they heal with scarring, usually take up to 6 weeks. Herpetiform, so-called because they look like herpes virus infections, but they're nothing to do with a viral infection. 1 to 2 millimeter in diameter may coalesce to form a larger ulcer, which heals within about 3 weeks. They may scar. So with Behçet syndrome, you get recurrent aphthostomatitis, ocular lesions, and genital ulceration, often in Eastern Mediterranean and Asian populations. Genetic and environmental or microbial factors may be a part. So with regard to red lesions, if we talk about localized red patches, may be associated with denture-related stomatitis, again candida or allergy, geographic tongue, or erythema migrans, lichen planus, erythroplasia, purpura, telangiectasia, angiomas, which are vascular lesions, so is carpocysarcoma, which is a malignant vascular lesion that occurs often in HIV or AIDS patients. Burns, lupus erythematosus we talked about earlier, lack of vitamin B12, or sometimes due to certain medications. So if we talk about generalized redness in the mouth, it may be due to candidosis or some sort of systemic problem through radiation or chemotherapy, or a lack of vitamin B12, mucosal atrophy or polycythemia. Benign migratory stomatitis or geographic tongue occurs in about 1% of the population. Irregular depapillated red areas, usually the anterior 2/3 of the tongue, and basically what you get is loss of filiform papillae, and you get this white outline with a red centre. Periods of regression and reappearance are common, usually symptomless, and may affect the lips and the cheeks as well. So here are some clinical examples of benign migratory stomatitis. Erythroplakia, like leukoplakia, is a clinical term. It's a bright red velvety plaque which cannot be categorized as any other lesion according to WHO. It's 1978. May be homogeneous with well-defined outline, or intermingle with patches of leukoplakia called speckled leukoplakia. There's a high rate of malignant translation in these lesions, the speckled ones, than leukoplakia. So here are examples of erythroplakia shown in different patients. Then other mucosal lesions, pemphigus or pemphigoid. Pemphigoid, where what you have is a mucosal or skin and mucous membrane disorder where you get fluid-filled blisters, and it's an autoimmune problem which causes a problem with the junction between the epithelium and the underlying connective tissue, so the epithelium lifts away. whereas pemphigus, again in a similar age group, but here the blisters are intraepithelial and it's anti immune complex problem where you get antibodies against the cement between epithelial cells, so it's an intraepithelial destruction. So with pemphigus, you diagnose both by biopsy and immunofluorescence, and in pemphigus you see IgG3 intraepithelially, and whereas with pemphigoid you'll see it below in the basement membrane zone. And basically you do high dose of corticosteroids, azathioprine or mycophenolate morphitel. In the past, sometimes gold is used for management. So here are some examples of pemphigus or pemphigoid. Clinically, they may appear very similar. So infections, again, this is going to be covered in a later lecture, but usually either viral infections cause ulceration, herpes most common, hand, foot and mouth disease, or varicella zoster, which is a chickenpox virus, and they're usually self-limiting. So here are some examples of lesions that can present. Erythema multiforme is a blistering ulcerative condition of unknown etiology. 50% of the cases have a preceding infection, either herpes simplex virus or Mycoplasma pneumoniae, or a drug reaction. So again here what you classically see is blood crusted lips and generalized ulceration. Usually in young adults, males are more affected than females. Prodromal symptoms: cough, fever, malaise and headache. Disease lasts for up to 2 to 6 weeks. It's self-limiting, but 20% of the patients experience recurring episodes. And here's that typical blood crusted lips. Erythema multiforme, 50% may develop skin lesions. Target or bull or eye lesions are quite common, whereas in the mouth you get necrotic, large, shallow erosions and ulcerations, crusting of the lips, and quite painful. Here's those target lesions, so it looks like a bullseye, and the oral lesions. I've just put these flow diagrams from Corson and Adele for diagnosis of red, white and mucosal lesions. This is a good flow diagram to follow in the clinical situation. And here one with for painless white patches. Just work through it, and if you had that in the clinic, that would be of an advantage to you. And again, a single red patch. You can also get further information on differential diagnosis of red and white patches in oralmednet.net, and if you register there, go to the student section. I've provided some extra clinical material which would be also useful for exams, but it would be more useful for the clinical situation when you come across a patient. Thank you very much.